All right, we're going to go ahead and get started. It's right at 12 o'clock. My name's Kate, and I'm really excited to have Patricia Robinson on with us today to talk a little bit about the primary care behavioral health model, and then more specifically some trainings that we're going to be offering in the fall through the Institute that we hope some of you on the line may be interested in participating in. So I'm going to, before we turn things over to Patty, I'm going to go ahead and say a few words about the Institute. And even before that, since that you all know that you're all on mute, it helps keep the presentation moving along if everyone's on a mute. But we would love to hear your questions, and there's two ways that you can ask questions. The first is to raise your hand so that you can ask your question directly. I will go ahead and unmute your phone line, and then you'll be able to ask Patty your question directly during the Q&A portion of the presentation today. To do that, you'll need to enter your audio PIN, and so if I see you have a hand raised but you haven't had the PIN entered, I'll go ahead and send you a reminder to enter that. It's just what allows me to mute and unmute your line for you. If the technology is too much trouble or you're not in a space where you can unmute your line, or if you just prefer to, you can type your questions into the questions pane. And you can actually do that throughout the presentation. So as Patty's going along, if you have a question to help clarify something, please feel free to forward it to that questions pane, and I will stop Patty briefly to address it as we go along. So for those of you who don't know, the Patient-Centered Primary Care Institute launched late last year as a public-private partnership between the Oregon Health Authority, the Northwest Health Foundation, and Quality Core. The goal is to offer a broad array of technical assistance to practices that are in various stages of transformation. And so the Behavioral Health Integration Project we're working on right now with Patty is just one part of those efforts. We're also hosting learning collaboratives with practices throughout the state, some of which I know some of you on the phone today are participating in. We have resources and information linked from our website, and we host webinars and are developing some online learning modules that will be available later this year. The Institute works in partnership, like I said, with the Oregon Health Authority PCBH program in support of the PCBH model of care. The model's defined by 6 core attributes, and then there are standards and measures that practices attest to in order to become recognized as a primary care home. And you can read more about the standards and the PCBH program on their website, which is listed at the bottom of this slide. And I'm going to go ahead and turn things over to Patty. Patty is she's a trainer and a consultant with Mountain View Consulting Group, and has worked with us to make this webinar, future webinars, and then in-person training opportunities available to practices in Oregon. We're really excited because she has a lot of national experience in this to share. And I'm going to go ahead and turn things over to Patty.
Hello there. Talking to you today from South Dakota, and I'm out here training in what's called Behavioral Health Optimization Program, which is what the United States Air Force calls the primary care behavioral health model. It's now a mandated service in all military medical treatment facilities worldwide with impanelments of 5,000 or more. So all have a full-time behavioral health provider that works as a member of the primary care team. So I'm working at Ellsworth Air Force Base today, and I get to see Mount Rushmore tomorrow after work, so I'm pretty excited about that. I've been involved in primary care behavioral health work since the late 1980s. I just kind of stumbled into it as part of a research team at the University of Washington, and then Center for Health Studies at Group Health Cooperative. And as we kind of just looked at some of the results of our studies, we were like, wow, how would we change how mental health services are delivered so that more is possible in the primary care setting, because really that's where most people go. And so wherever people go is where they want to be served. So it took years, really, to kind of come up with a model, because the model has a lot of specific kind of details associated with it. So you have to test different kinds of processes. You have to look at training, what kind of training is required to get people ready. So that took a while. And kind of culminated, I guess, for me, after I left Group Health, I went to Yakima Valley Farm Workers Clinic and worked in the Toppenish Clinic for 6 years. I really wanted to figure out how do we take primary care behavioral health services and adjust the model so that it really works with underserved folks. And so that was the Toppenish Clinic was a great lab. I had great primary care partners to work with, and we really discovered a lot, and that kind of resulted in the book Behavioral Consultation in Primary Care, a guide to integrating services. That was published in 2006. My co-author, Jeff Ryder, and I now, just a few weeks ago, signed a contract with our publisher, Springer, agreeing to a second edition, and we plan to launch a website for the book and to put some videos up there for folks to look at so you can better imagine some of the skills that we describe, better imagine and learn the skills we describe in the book and in the second edition as well as the first. Real Behavior Change in Primary Care is a book that takes contextual behavioral science. It's kind of the latest in cognitive behavioral therapy and applies it to the primary care setting. So it describes techniques for the most common problems in primary care, medical and mental health. It also describes interventions that primary care clinicians, as well as primary care nurses and behavioral health providers that partner with them, can provide. So these are very brief interventions, in some cases only 2-3 minutes, in other cases maybe 5 or 10 minutes, but really adapted and evidence-based for primary care. So those are some resources for you. You can look at my resume that's available on the website and see other publications. And if there are things that you would like me to send you, I'm very, very open-handed with anything that I've written that can, that's consistent with copyright laws. I can send out, and I can send out quite a bit of stuff. So moving on to the next slide. Oh, and I'm moving it on. I forget. I tried to move it on. Kate, would you or Ann move it on?
You got it there. It just takes a second to move forward sometimes. So now I think it moved forward too. So you might just want to move back, use your arrow keys to move back a slide, and that should take you back to where you want to be.
Well, it's not moving on mine. That's the problem. So the other thing I'll do is I'll just pull up.
Okay. Well, we moved it back to the agenda slide if you want to start from there.
Okay. The other thing I'll do, just as a backup, Kate, I'm just going to open my PowerPoint that I have, so I can keep going if I have trouble with it. So I've got that up, and I'll try it one more time with, oh, okay, well, it's moving. Okay, agenda for today. Sorry, you guys. Okay, so the first thing I want to do is just talk to you about this model. Some of the details, there's a lot of details. But to give you a big picture, kind of the key elements of the model, I would also like to describe the current Institute training opportunities, and then allow some time, maybe 10 minutes or so at the end, to take questions. Your questions can be about the model. They can be about your application for the trainings planned and coming up in October and again next year. Also, webinars are a part of it. So if you want your question answered now, do what Kate said, just type it in, because I'm very comfortable with just kind of answering questions when you have them. But if you want to wait till the end, that's fine too. So whatever way works best. So I'm going to move to the next slide now, which is the integration continuum. So back in the 90s, some of the studies I was fortunate enough to participate in really kind of looked at co-located models. So we had specialty behavioral health providers or members of a research team that were trained as specialty mental health providers go into a clinic and provide services. We tried to make them look more like primary care services, so they were briefer, sometimes delivered on the phone, but in those co-located kind of days, the behavioral health resource really wasn't a member of the primary care team. They tended to be kind of part-time or kind of there for a while and then gone. But the co-located kind of phase of evolving the primary care behavioral health model was really important because a lot of studies were generated at that point, and it really is kind of the tradition in research that we do that in kind of a diagnosis-specific kind of way. So that led to more collaborative care and targeting a single population. An example of that is like the impact model. And that's another step towards broad integration efforts. And then the kind of the ultimate approach in terms of providing behavioral health services in primary care is the model that I'm going to talk about today, and that's the PCBH model, or the primary care behavioral health model. This is the model that has been implemented in the United States Air Force and some 75 different military medical treatment facilities. And what they're finding is about 90% of the people have their needs met in this model of care. And so that's pretty good. And I'll review some of the other data behind this approach momentarily. But I will say that basically there are two services provided in the primary care behavioral health model. First, there's brief interventions, and second, there's pathways. So I'm going to describe those a little bit for you. Well, by the time I get to the end, I'll figure this out. Maybe it's a double click. Okay. Okay. Hopefully I didn't do two. So this model embeds mental health professional within the primary care setting to serve as what we call a behavioral health consultant. So you'll see the abbreviation BHC. We felt it was very important to put consultant in the job title. That is because it distinguishes many of the services that the behavioral health provider provides from services that they might provide in a specialty mental health or chemical dependency setting. So a consultant is someone that advises the primary care provider, advises the patient, makes recommendations. But a behavioral health consultant doesn't have a caseload. They don't pull people off, but they teach, supplement what's available in primary care. But the primary care provider, primary care clinician remains in charge of the patient. So the goals in this model are basically to improve detection, diagnosis, and treatment of psychological issues, and to assist patients in developing skills that they need to improve and maintain good health. For many years, it kind of puzzled me that we talked about health as kind of the absence of disease, when in fact we're all declining from about the time we're 18, 25. I think we're still figuring that out. And the slope of that decline depends so much on our skills. So the behavioral health consultant is part of the team and part of the effort to provide skills. So really skills to maintain health so that health is as good as possible for as long as possible.
Hey, Patty, it's Kate. Really quickly, two things. We're moving the slides forward, so when you're ready to go to the next one, if you just say next slide, we'll move it forward for you. And then the other thing is if you could speak up just a little bit louder.
You betcha. How's this?
That's better.
Okay.
Yeah.
I'll keep it that way, and we can move forward. Thanks, Kate. I was like double-clicking and this and that. Okay. So let me introduce you to Mary Virginia Maxwell. This is a picture of a behavioral health consultant that I trained a while back. She works in a clinic that has 7 pediatricians or pediatric providers. Some are pediatricians and some are mid-levels. And she is walking around. You see her outside the exam room there. She has a basket of toys, and she actually works in exam rooms. She doesn't have an office, although some behavioral health consultants do have an office. The office is always located in the heart of primary care, kind of equidistant from all the providers, so that access is good for everybody, as good as possible. So she's providing the 2 services I mentioned, the brief interventions. And when we describe brief interventions, we say take all comers. So when the behavioral health consultant goes into primary care, basically the message to the primary care providers and nurses is there's no wrong referral. Refer everybody, and we'll provide the behavior change expertise and get back with you. Now, most of the brief intervention visits are on the same day as the patient's medical visit, such that the patient doesn't have to return for a future appointment and pay the money for transportation or take the time off work or find daycare, all the things that get in the way of people being able to get the services they need. So, of course, the template for the behavioral health consultant is set up consistent with the principles of advanced access and always has been. So half or more of the visits on a daily basis are same day, and all visits are 30 minutes. Typically, follow-up visits are a little bit shorter, more like 20, 25 minutes, but that just gives the behavioral health consultant a little flexibility with initial visits, which typically are completed in 30 minutes, including charting. But if it's a translated visit or more complex, get a few minutes by kind of working with follow-up visits tending to be shorter. Kind of the difference between the initial and the follow-up is simply that behavioral health consultants don't do the standard kind of introduction that they're trained to do. And they don't have to do kind of the target problem analysis that is typical in the first visit, because that would already been completed. The other type of service that the behavioral health consultant provides is a pathway service. So pathway services are plans made at the clinic level to consistently use a behavioral health consultant to improve outcomes to members of a target population. So these services can be assessment services, individual services, or group services. Okay, Kate, we can move forward. All right, so here's the flow, okay? The physician identifies a referral, and many times the medical assistant or medical technician may be completing screening questions, and they may identify and just give the primary care clinician a heads up. And it's such that the behavioral health consultant can see the patient before or after the medical visit. Once things get rolling in a clinic, the primary care clinician can use the behavioral health consultant to help them get caught up when they're running behind, because they can say, just, I want you to go in. I told the patient, you know, that you were going to drop in and do some education on this or assessment on this. And so they can go in, and then the primary care clinician can catch up, and their visit ends up being shorter by virtue of having part of it completed by the behavioral health consultant. So they refer, and often on the same day. And then let's look on the right-hand side at the more kind of royal blue rectangles and go through these boxes. So these are the components of an initial interview. So first, there's an introduction. So the introduction is really important because this is a new service for many patients. So it really orients them as to what to expect from the service. I typically recommend that behavioral health consultants have a brochure that describes the service, and to give that brochure to the patient at that initial visit. The brochure is not only kind of informs the patient, but many times it's taken home, it's shared with somebody else in the neighborhood or the community. So it gets the word out about the availability of this service in primary care. So the introduction is really important in that way. Kind of also includes how the visit's going to be structured. It informs the patient that the behavioral health provider is a part of the team and charged to the medical record, and gives them a chance to ask any questions. Also, part of that 5 minutes of introduction is completing an outcomes measure. And so the measure that seems to make sense for almost any patient referred to the behavioral health consultant, and I guess I would say almost any patient coming to primary care, is a measure of health-related quality of life. I have used over the years with success the Duke Health Profile. It's a 17-item survey normed on primary care, and produces scores that are easy to understand, and these scores can be used in aggregate, and they're quite useful clinically. This measure can be repeated at all follow-up visits and used to help determine whether or not the plan, the treatment approach is working, and whether the patient's quality of life is indeed improving. So the introduction and outcome measure in the first 5 minutes. And the next 5 minutes is just trying to get a picture of the patient's life context. Sometimes we call it just a snapshot of their life context. Well, why is that important? Well, you want to know what their resources are. You want to understand their strengths. so that you can utilize those. And you want to start to form a relationship with them quickly. So as part of training, I teach a series of questions that feel kind of social in nature, very consistent with the context of primary care when you think about what you experience when you go to your primary care provider. And again, it's a lot of training for behavioral health providers to kind of move from that whatever 4-page psychosocial assessment to a 5-minute interview, and do it in a way that's engaging with the patient. So the next part of the interview, and that's kind of the heart of the initial interview, is the functional analysis. So that's taking the specific problem targeted in the consult and really understanding it from a behavioral perspective, kind of when it started, how often it happens, what triggers it, kind of the intensity level of it, the impact of it in different areas of life, what the patient's tried, how that's worked, how consistent their efforts at problem solving and coping are with their values. So that's a very, very important part of the interview, and it really reveals the information that's critical to coming up with an intervention that's not only evidence-based, but really matched to that patient, their resources, their cultural beliefs, their readiness, and then to give in that, as we move towards the end of the visit and concluding it, to provide a good problem summary statement, check for patient engagement, and then move into specific behavior change planning. This is also the time when the behavioral health consultant will be teaching skills, will be providing information on occasion, some handout with more information that the patient can review later or use as a reminder of what is covered in the actual visit. So at that point, we're up to 20, 25 minutes, and then we can move into charting and feedback to the primary care clinician, and about 5 minutes allowed for this. So those are the components, and as I said in a follow-up visit, you're not doing the introduction, but you're doing the outcome measure. You don't need to do the snapshot. Many times you don't need to repeat the functional analysis. So you have a lot more time for skill training, guided rehearsal, really making sure the patient knows how to do something different and has a specific plan to do it that they feel confident about when they leave, because it's all about what they can put on the streets. That makes the difference in the long run. So as I said, mostly same day, feedback same day, and then patient visits it varies. I mean, in this model of care, you can see somebody back the same week if you need to. Typically, you're going to give them a little more time, usually about 2 weeks, so they can really take that plan and go out and work it, and experiment with it, get some information about how that's going to work, and then come back and work with the behavioral health consultant again, or maybe see the primary care provider in a medical visit who can then support the plan. Lots of different possibilities, but the bottom line, it's about skills. And the primary care clinician is retaining full responsibility. So.
Hey, Patty, really quickly, we had someone ask, what are the qualifications of a behavioral health consultant?
Yeah, well, it's a licensed behavioral health provider, basically. So we want somebody licensed. It could be like a counselor, a social worker, a psychologist. I've trained a few psychiatric nurse practitioners as well. So that's typically who does this job. Okay, we can move forward. I will say, you know, as primary care behavioral health services develop in a clinic, sometimes too, the clinic will decide like to hire a behavioral health consultant assistant. So that might be someone with a training similar to what a technician or medical assistant would have. In fact, people that have worked as a medical assistant before often are great behavioral health consultant assistant. So that really helps the behavioral health consultant be more efficient because this kind of behavioral health consultant extender can actually do the outcome measurement, kind of triage, same-day visits. So I had an assistant when I was working at Farm Workers, and so rather than seeing, you know, completing 10 visits a day, which is typical standard, I was able to like complete 12 and 14 by using my assistant. Brief intervention services, as I said, they're 15 to 30 minutes. I'll just say this, it's a model of care where even 10 minutes is better than no service delivered while the patient's there. So there's ways to kind of flex those components so that you can meet some needs even when you're really busy. So as you probably got an understanding from just my description of the components, the behavioral health consultant, or BHC, is very directive. And the reason we developed the model this way is that research suggests that these concrete clinical actions actually do predict early clinical improvement. So we train behavioral health consultants to be directive. So they do things like set the agenda, give kind of a briefing to the patient about what's going to happen. All of those things, the life context, target problem analysis, education, teaching skills, and then monitoring the patient's adherence or skill acquisition over time are all part of to obtain those early clinical improvements. Okay, Kate, we can move forward. Kate didn't move for me. How are we doing?
We moved forward and we can see it on our end, so hopefully you're still connected. It's the PCBH pathway slide.
All right. So here we go. So pathways are, you know, identifying a patient population that's high impact. So high impact because there's a lot of patients in that population, like depressed folks, or because of the way that the patients in that group present. So an example of that would be like patients with chronic pain who typically are not very satisfied with their care because their situation isn't changing. And so, you know, they may call nurses quite a bit, requesting, sometimes demanding various things. They may go to the emergency room. Sometimes they struggle with primary care providers in visits. So high impact, not because there's a huge number of them, but by the way of their presentation or the outcomes, that we're just not getting good outcomes with them. For example, with patients with diabetes, our outcomes are not that good relative to what we would like. So patients with diabetes is often another population. Another population is like overweight, obesity, just a huge problem. And so any of these can be like a target, and it's the individual clinic that gets to decide what population do we want to target. And then they look at the evidence, and they look at what they're currently doing. Sometimes we just end up doing stuff that we're just doing, and when we look at the evidence, we say, well, we could change. You know, what we're doing takes quite a bit of resources. You take, for example, the chronic pain patient. You know, all of those services we're giving out, you know, add up significantly. So maybe there's a way for us to increase efficiency and improve clinical outcomes at the same time. So it kind of takes the courage to kind of look at what you're doing. Are you able to measure the impact of what you're doing? What's the evidence, and how can we change that consistent with what resources we have? And resources includes, you know, of course, the enthusiasm of the people at the clinic, their willingness to work on that. So, yeah, and it's hard, but, you know, we need to look at the way we're going to evaluate the processes and outcomes associated with the pathway. And they can be modest, and, you know, and oftentimes they're measurements that you already have in place. So it's just a matter of kind of tapping into them and getting them kind of corralled within your electronic health records. So we can move to the next slide, Kay. So here we have kind of a picture of, this is an exam room poster. I think this is from Mary Virginia's clinic, and it just shows a picture of a family, and describes the behavioral health consultation services, what it is and what kind of services are provided and how the patient can get them. So this, in a way, can be kind of like a pathway. So it's like we want to give behavioral health consultant services to anybody who asks for them. So that requires that people know about them, all of them. But let me give you some other examples of pathway services. There's screening services. An example would be like neurodevelopmental screening at ages 18 and 16-month well-child visits, using just a single screening question by the pediatric provider, and then an exam room poster. What we took is like the 6 most robust items from the MCHAT. And, you know, patients are sitting there with their 2-year-old, and they're reading what's on the wall. So it says, if you answer yes to 2 or more of these, notify your doctor, and that triggers the same-day visit with Mary Virginia, who does ages and stages, social, emotional. So example of kind of a pathway focused on screening, and then you can add on to that specific interventions that might be delivered at the level of the behavioral health consultant. Example of one-on-one interventions. So a behavioral health consultant can be called in to a well-child visit anytime a 2-year-old is overweight. Classes or workshops would be patients who you could screen for sleep problems and smoking, just a patient check-in, and anybody positive receives a half-page flyer on a sleep hygiene class or a smoking cessation workshop. Group medical visits, pathways often for patients with chronic conditions involve what's called group medical visits. And these are like typically monthly visits where both medical and behavioral health services are delivered, increases efficiencies, gets more service delivered, and provides that social and emotional support that patients need in coping with chronic conditions. So pathways are very flexible and very important part of the model. So next, okay. So lots of skills that the patients learn in brief interventions and in pathway services. So I've talked quite a bit about this. The results are, when we practice this way, we're focused on skills, focused on same day, using things like behavioral health prescription pads, monitoring at follow-up, we get better results. So we'll move to the next slide and talk just a little bit about evidence. Because this model's been around long enough, we have quite a bit of evidence for its use. First, we see improvement in patient symptoms and functioning. Specifically, we see clinically significant change across very few treatment sessions. So we see over 70% responding with an average of 2 visits. So some patients come for 4 or 5 times, many come for 1 time, get some information, skill training, and run with it. Of course, this model is such, if they need help in 3 months and need help in 6 months, they just come back. And, there's no opening a case or intake or anything like that. The improvements are not only in symptoms, but also in functioning and life roles and in social relationships. These changes are robust and stable over a 2-year period. So we have 2-year follow-up studies at this point, involving not just a few patients, but over 500 patients. So what about the patients with more severe impairment at pretreatment? Well, actually, they benefit too. And, of course, because they have more room to change, they're moving faster. They do use more visits. And next slide. So we get better engagement of patients with this model too, so better retention. One of our first studies at Group Health, we did a 4-session protocol with people with probable major depression. It was 4 to 6, 30-minute visits. Patients could choose. We considered completers people who completed 4 sessions. We had 91% of the people who came to the first visit completing 4 visits. So that's just huge and helps explain why it is that we get the results that we do clinically. Also reduces healthcare costs, obviously, because it shifts the burden of behavioral health care from primary care clinicians to behavioral health providers. It reduces the workload of primary care clinicians. And I tell you, one of the best ways to sell this model to folks is to have a primary care clinician who's worked in this model say, yep, after we started that, I started for the first time in years being able to go home on time more often than not. And that's just huge. I mean, burnout is a big problem in primary care work. It's really tough work. And we need to look at provider retention and continue to look at the impact of this model of care on primary care clinician job satisfaction and stress level. Also evidence that it strengthens doctor-patient relationships. And we can move forward, Kate.
Hey, Patty, really quickly before we get started with talking about the training, there was a couple of different questions that maybe you could speak to before we start on the next section. So one was, have you worked in a setting that integrates care managers, behavioral health providers, and a dietitian, coming from a pediatric clinic that's interested in fully integrating what are currently somewhat siloed behavioral health and dietitian services? And then how do you engage patients around that?
Okay. Yes, I have, and I am this week actually, and I have in other settings as well. And I think it's a great opportunity to take a team approach, and many things are possible. I'll just give an example. Like when I was at Farm Workers, we had a diabetic nurse educator, and our pathway was that any one aspect was any newly diagnosed diabetic was referred on the same day to the nurse educator or myself. It was just whoever was open first, and whoever saw him first took him to the other one. We actually ended up using the same materials in a workshop that for patients that we offered on a regular basis. The place where I'm working this week, they have a diabetes nurse educator. They have a dietitian technician, and they have a behavioral health consultant. And along with the primary care clinicians, they're all a part of a pathway, and they all have specific things that they do for the patient. And there's a lot of supporting each other's interventions. I often train primary care clinicians, primary care consultants to get this going by being the person that kind of evaluates the patient's readiness for specific areas of behavior change associated with strong self-management, and then informs the team as to, let's work on this first. Let's work on this first, so that we're able to build the patient's self-efficacy. Does that kind of give you ideas?
Yeah, and if the person on the line wants to let me know if they have any follow-up questions or raise their hand and I can unmute their line, I'm happy to do that as well. One of the other questions was, more closely related to how this provides economic benefit to a primary care physician, and I know that the billing for services can be a very varied experience, and there's a lot of work going on in Oregon and other places right now to take a look at this. But Patty, I was wondering if you could speak more generally to what are some models that people have used to bill for this. How does it provide economic benefit for a physician, just in a general sense?
Sure, be glad to. Ways to look at it is to look at the utilization of your high-impact patients. So somaticizing patients, patients with chronic conditions, patients with chronic disease, that's where you're going to save a whole lot of money. So rather than them hanging out with their primary care clinician, you're going to have them checking in more frequently and learning the skills they need from a behavioral health provider. I've had a number of clinics actually that cost modeled the impact of having a behavioral health consultant that was actually just providing some individual and group services for chronic pain patients, and just cost modeling on an assumption of 60 chronic pain patients. The use of medical services was reduced enough to pay for half of the salary of the full-time behavioral health consultant for a year. So that's really a great way to look. The other thing to look at is physician retention. So there's one study out there, I don't have it on the tip of my tongue, but there's one study that it costs like tens of thousands of dollars to recruit a primary care clinician to a practice. So if we lose that clinician because he doesn't want to see, as one doctor told me recently, I can't take it if I have to see another non-compliant diabetic. It's just not, my thing. I came into medicine to help people. So if we can reduce the loss of physicians, reduce burnout, that's huge. That's a huge cost savings and a huge benefit to the system and to the individual primary care clinician. I'm not going to get way into billing because I'm aware of the time and kind of trying to stay in my lane, and Kate does that kind of thing, does the billing thing.
Okay, so Patty, just one more question, and then I think we need to move on with the slides about the training opportunities so that folks on the phone who are on the phone to hear more about that can hear that too. But one question was about the pathway services. Have you noticed if patients are more willing to come to group sessions during the day or evenings and weekends?
You know, it depends upon the group. So people that are working and have, you know, kids or whatever, they may like that Saturday morning deal. If you're trying to target mothers of young children, sometimes right before they pick them up at school is a good time. Older adults, they love the late morning or early afternoon. It gives them time to get going. Their availability is pretty good. So it depends on the group service and who you're targeting.
Okay, so if you want to just talk the next couple of minutes, Patty, about the training opportunities, we'll switch gears. Those of you with some of the outstanding questions, I'll see if we can connect with Patty over email and maybe email you some responses. We have the email addresses of everyone who has signed up today, so we can see if we can send you some additional resources over email if that's possible. But Patty, do you want to talk a little bit about the sessions, or is that something that you'd like me to walk through? Or
No, I can do it real quick, Kate. Thanks.
Okay, great.
So week-long trainings, one October 14th and the second the 21st. Basically, Monday is an introductory session, and we really would like to have multiple members from a clinic. So a provider, office manager type person, operations, behavioral health provider. And then following that up, Tuesday through Friday is more intensive skill training in brief interventions and pathway services. So really preparing for boots on the ground and teaching a lot of clinical interventions, but teaching those components of the interview, teaching those outcome instruments, screening instruments, how to create pathways, devil's in the details. So that would be the rest of the week. And then next slide. I think on that introductory day, I also will do some kind of foundation skill training for the primary care providers or primary care nurses, and help you kind of do a team-based assessment and identify targets for moving forward in your clinic. I'll also provide you with a CD that has a toolkit, including a template for a practice manual, a PCBH practice manual, and some support tools. We're working on those toolkits right now. And next page, yeah, I think I covered everything, but they're really going to work to master their understanding of the procedural manual, and so that they can teach other team members when they go back to their clinic, kind of become the experts in their clinic. We use a lot of different techniques in that training: modeling, video demonstrations, role plays, and didactics, but we keep it pretty alive and kinesthetic. So those of you that learn from doing will like that training. Yeah, you get a little graduation certificate at the end. And then moving on to the next slide, spread and sustain. So there'll be 2 to 4 practices they'll have the opportunity to receive additional training to become best practice sites, and that will be in January or February of next year. So the goal really of this training is to spread and sustain the impact of the week-long trainings within regions and communities, or groups, or health systems. because, you know, we go to a workshop, we learn a lot, we try to kind of keep going, but we need to think in terms of developing best practice sites, people that want to be teachers of this, that want to have people come and visit them and see what they're doing and kind of tweak their approach. And so that's what that's about. With that, Kate, I'm going to turn it back to you. It looks like we have about 5 minutes for questions.
Okay, thanks, Patty. If there are any other questions that people want to, again, ask by raising their hand, so there's a little hand icon in your GoToWebinar control panel, or type in specifically about the training opportunities that are coming up, or more generally about the PCBH model that Patty talked about at the start of the presentation. We have just a couple minutes left where we could take your questions if you have them. So one question was about signing up for trainings, which is a great question. So the Institute website is www.pcpci.org, and I think on the next slide we may have even listed the website. And then on the main page that you'll see that there's a call for applications, and there's pretty detailed information that goes over what Patty referred to in her slides. So the dates, the locations, the general topics, who should take part in which piece of the training, and there's a link to an application. We don't know how much interest there's going to be, but there's a certain number of slots per region, so we're just having people fill out some, pretty basic application that's sort of about their practice and where they are and why they want to participate, so that we can collect that information from people. One important thing is that there is the application is online. It's through SurveyMonkey. But we've also linked to that web page a PDF version of the application, so people can kind of take a look at what's involved before they click to the online application, just to make sure they have all the answers before they sit down to do it, because we've found that people find that easier. The web page also lists contact information that you can use if you have questions about, whether or not this training would work for you, or any of the logistics things. You can email info@pcpci.org, which is the address that's listed on that site. And I'm happy to get in touch with you then via email or even a short phone call to talk through with you any questions you have after you review the information that's available on the web. So I'll give just another few seconds if there are any other questions. Let me make sure I've scrolled through here and gotten everyone who had a question. The other thing is there's going to be a survey that comes up as soon as we end the webinar today. We'd very, very, very much appreciate your feedback on the webinar, and then there's also an opportunity for you to ask additional questions if you have them, and we'll do our best to find some answers or some resources for you and link those to you via email. The slides and a recording of this webinar will be available on the Institute website later today. The slides are up there already, actually, and there's also a list of references. So you'll notice there were some references to some research and articles throughout the presentation today, and the list of references is available on the website as well. So let's see, is this appropriate for clinics that are already integrated with behavioral health consultants? Patty, could you speak to that?
I think kind of the quick answer is, do you have pathways developed? Is your behavioral health consultant completing, on average, 10 visits per day? Are patients satisfied with services, and are all primary care clinicians referring a wide variety of patients, including patients with medical problems such as hypertension, weight, hyperlipidemia, diabetes, chronic pain, as well as mental health, traditional mental health problems. you know, if you've got all that going, the chances are good that they have pretty good training. I would ask them, you know, to kind of do a self-assessment and use those metrics. I guess another thing is, do they have any group medical visits going? Do they have any workshops, classes? Those are all the things that we would like to see happening in primary care behavioral health service that's functioning well.
So I think, you know, the short answer is if you have a lot of those things or all those things in place, then this training may be a little bit for people who are looking more to get those established. But we may in the future be able to offer some more advanced help through the Institute. So if you email that info@pcpci.org and just let us know you're interested, we can keep you into the loop if there are any more training opportunities that are more appropriate for where you are on the spectrum of things. So I know that everyone's wanting to finish up their lunch and get back to work, so we're going to go ahead and end the webinar today. Please do take that survey, and we'll be in touch with anyone who leaves us any additional questions. Thanks to everyone who made it here today.